Hello, Sabaidi, and welcome to topic 6.2, Descriptive Study Planning. By the end of this topic, we hope that you'll be able to identify descriptive study designs and when they're best used in research, and be able to begin the foundations of planning a descriptive study, including choosing the best study design for your goal, establishing analytic methods and plan, selecting the appropriate measures, and controlling for bias in both your planning and analysis. While some of these steps won't be fully covered until future topics and modules, you can begin to move forward with your planning. As discussed in topic 6.1, descriptive epidemiology aims to characterize people with a health condition and the population at risk by time, place, and person, in order to see patterns in who becomes a case with the condition or who is at risk of becoming a case. Descriptive epidemiology is the investigation of the frequency of events within and across populations and the foundation upon which we can build and test hypotheses about why and how these patterns occur, with the ultimate goal of intervening to change the condition. In describing a health condition, we need to understand who has the condition in question. We typically describe the population at risk or with the condition through socio-demographics such as age, sex and gender, or occupation. These two figures are examples from the 2017 Laos Social Indicator Survey. The top graph shows how stunting, the blue line, underweight, the yellow line, wasting, the red line, and overweight, the purple line, are distributed by age and months in the Laos Social Indicator Survey. The graph on the bottom is an excellent visual display of disparities in stunting by different population descriptives, such as rural versus urban area, poorest and richest wealth quintiles, maternal education from no education to higher education, ethno-linguistic group, and province of residence. This graph really tells a story about who experiences stunting in Lao PDR. Understanding when a condition occurs or does not occur is also important. This may include a description of the time between exposure and disease occurrence or seasonal variation in a disease condition. These graphs display the number and percent of positive influenza tests reported to the United States Centers for Disease Control and Prevention over the weeks of the year, which are along the bottom, for 2018 to 2019 on the top graph, 2019 to 2020 in the middle graph, and 2020 to 2021 in the bottom graph. Not only do we see a seasonal variation in when people test positive for the flu by this distribution, but we see how that pattern is wildly disrupted by over the last 3 years. I believe you can imagine why these changes exist, but this is an excellent demonstration of how powerful even very simple descriptive data can be. We can also describe disease conditions and populations by where the condition does or does not arise. Where, in this context, can refer to geography, such as the map demonstrating the prevalence of stunting by region of Lao PDR, or it can refer to a setting, such as this graph, showing the consumption of types of snack foods in different settings from the World Food Programme Snack Study in Lao PDR and the Philippines. Describing where a condition arises can tell us where an environmental or geographic or climate exposure may exist, but it often indicates another risk or exposure that is related to place, like socio-demographic factors. Finally, we can often find clues about how or why a condition arises or changes patterns with descriptive studies, even though we typically investigate the why with analytic studies. For example, when we looked at the influenza charts, we could see the disruptions to influenza patterns caused by COVID. We can also deduce that there is a relationship between stunting and socioeconomic status by looking at the patterns of stunting across those indicators in the Lao data. And we can generate some hypotheses about why kids eat specific snack foods in certain settings. In each of these cases, we compared natural groups or changes in time in these data that allow us to see differences in our condition. In planning any study, we want to ask ourselves, so what? What is the potential impact of our study, and should we be focusing our time and resources on this issue? There are many existing descriptive studies and reports. What can we contribute that is new? Is this an important study to do and to use resources to implement? Is the condition we're studying serious or widespread or have a broad social impact? Is it political in that evidence is needed to convince stakeholders or to justify channeling resources to the condition? One thing I noticed in the SRG applications was a common concern about obesity and overweight in Laos. This appears to be an emerging condition in Laos, and particularly in urban areas, so there may be justification for studying it in order to develop interventions to prevent obesity from becoming a more widespread issue. To plan a descriptive study, you need to first understand the uses of descriptive epidemiology, compare study designs and the bias associated with each, choose the best study for your goal, know the most important factors in creating methods and analytic plan for descriptive studies, be able to calculate the measures of disease frequency or disease association, and control for bias in planning and an analysis. These are the essential components to planning a descriptive study. With every study design, we'll show you again where it fits into the strength of evidence contributed to the field. And this shows that descriptive studies provide the foundational evidence upon which we build our analytic studies. We can divide descriptive studies into two groups, those that use individuals as the participants or cases counted, which are case reports, cross-sectional prevalence surveillance studies, and those that use data at the population level only, known as ecological correlational studies. First, we'll briefly talk about case reports and case series. These studies usually report the first or early occurrence of a condition or an unusual condition. They're often reported by a clinician and are more common in clinical medicine, but they can play a very important role in alerting public health and medicine to a new disease or new epidemic. There are no statistics used in case reports. They are a qualitative description of what the clinician or clinicians encounter, but may be followed up with a larger study to investigate patterns and causal associations. A case series is simply multiple case reports aggregated into a single report. So this might be multiple cases or a single case seen by multiple clinicians. I don't want to spend too much time on case series and case reports, as I suspect that you will all be less likely to use them in your work, but there are links in this slide to examples of a case series and a case report. The case series describes the 5 cases of pneumocystis pneumoniae in men in Los Angeles, California in 1981 that were the first cases of AIDS that heralded the HIV epidemic in America. The case report focuses on a single young woman traveler who had a confirmed case of Zika virus in Italy after traveling to the Dominican Republic in January 2016, leading the World Health Organization to declare a public health emergency of international concern in February 2016. You can click on the links in this slide if you would like to read those case reports and case series reports. In summary, the role of the case report and case series are to recognize and describe new diseases, detect drug side effects, study mechanisms of disease, new approaches of treating diseases, or to recognize rare manifestations of disease. Again, they are strictly qualitative descriptions and are very easy and inexpensive to do. They have a weaker strength of evidence and limited potential to establish causal effects and may not be generalizable if they're describing a rare or unusual condition. The next type of study with slightly greater strength of evidence is the ecological correlational study. In an ecological correlational study, a researcher makes comparisons between variables where the unit of analysis is aggregated group data, such as in a country, to investigate crude associations between exposure and outcome in whole populations, not individuals. It is most often conducted using secondary data at a whole population level, like a country, and is used for an initial search or analysis, or for environmental context to generate hypotheses. You typically measure how linear the association is between an exposure and an outcome, so you use measures such as correlation coefficient, or R-square, or linear regression. However, there can be major issues with bias in ecological studies, primarily with confounding and the ecological fallacy, which we'll discuss. Here's an example of global ecological correlational data showing child mortality by prevalence of child wasting in 2020 for countries that have these data. The data are compiled from multiple sources by World Bank, and while this does not display a correlation coefficient, you can download the data and perform the correlation if you'd like. Mortality and prevalence data are each at a country level. They do not represent individuals, but an indicator at a population level instead. Our second example is a correlational study published in the journal Lancet in January of this year, and shows the impact of vaccination for COVID-19 on cases of COVID, visits to emergency departments, hospitalizations, and deaths in the United States. They compiled data from multiple sources, including jurisdictional health departments, national surveillance programs, vital statistics, and others. Yet only 31 of 50 states in the United States had consistent and reliable reporting of COVID cases, and we know that COVID cases were drastically underreported. However, during the time period of the study, case reporting was a bit better than it is currently. These incidence rates and rate ratios that are shown in the graphs, I know it's difficult to read, but you can get an overall sense of what they're showing, are all in individuals ages 50 and older or 65 years and older. And the trends showed that as the vaccination program was rolled out, cases, emergency department visits, hospitalizations, and deaths decreased in each age group, but particularly in the oldest age group, over 75 years of age. These ratios of relative change were modeled using linear regression, and while I don't have the regression coefficients here, you can also click on this link to visit the paper if you'd like to see how those were calculated. This is a great example of having to compile data from multiple different sources. Therefore, it is representative of a population level and not necessarily individual level. However, the immunization data are individual level, but because some of the data are population, you cannot use the individual level risk inference. This example is one of my favorite correlational studies, even though it's a bit old now, from 1996. It was one of the first in the United States to show the correlation between income inequality and mortality rather than just poverty level. The Robin Hood Index, which is shown at the bottom here, is a measure of the difference in highest and lowest incomes, or income inequality, and was calculated for each state. This was correlated with mortality adjusted for age in each state, and there was a statistically significant positive linear relationship between income inequality and mortality, meaning where inequality was high, mortality was also high. This was a moderate correlation at 0.54, and significance remained even after adjusting for poverty, as shown in Table 1, and across multiple mortality causes. As mentioned, the common measures used in ecologic studies are linear measures. We haven't talked much about statistical hypothesis testing yet, but we will, and I wanted this here for your reference. The statistical hypothesis in correlational tests is that there is no linear relationship between the two variables, represented here as Spearman's rho equals 0. The alternative hypothesis is that there is a linear relationship, or Spearman's rho does not equal 0. You can conduct hypothesis testing to determine whether you have a linear relationship. Ecologic studies are fairly practical, quick, easy, inexpensive method of investigating trends, relationships for hypothesis generation, or providing evidence for future studies to be conducted on an individual level. Using secondary data, sometimes from multiple sources, is efficient, but can also require quite a bit of work to access. These studies are an important means of investigating some relationships that cannot easily be measured at an individual level. For instance, you couldn't measure income inequality in an individual person because inequality by definition needs something for comparison. They're very good for conducting surveillance of the effect of policies, including those that impact economics, the environment, or social change. The ecologic fallacy is a form of bias that simply means that you cannot take conclusions made at the population level and apply them to the individual. You cannot assign individual risk based on population level data. This is often conflated with the idea that correlation does not equal causation, but you can mistake or erroneously correlate for causation in every study design. However, the ecologic fallacy also occurs when you try to use, for example, a mean to represent individual data in which there's a skewed distribution, like applying mean income in a city to say that any one individual person in that city makes that exact amount of income. A major bias in ecologic studies is that there's lack of information on confounding variables. You can measure and control for some of the factors if you have the data available, for example, how the income inequality study controlled for poverty. You cannot establish temporality in ecologic studies, but you can often conduct them before and after a policy change or rollout, such as the mass vaccination effort, to evaluate changes in a relationship, like in the COVID study. Because they measure factors on a population level, ecologic studies are very representative of the population. But the very definition of the ecologic fallacy says that we cannot generalize to an individual person. In addition, populations are very different, so you cannot generalize from one population to another. Next, I'll discuss surveillance, prevalence studies, and cross-sectional studies together. Cross-sectional or prevalence studies are probably the studies many people are most familiar with because most surveys and polls are examples of a cross-sectional design. These studies describe the health of populations and trends in behavior and risk factors, and typically characterize the population by socioeconomic factors, or person, place, and time to establish patterns of risk, behavior, or disease. You can think of surveillance prevalence studies as descriptive and cross-sectional as analytic versions of the same design, but they're all essentially interchangeable. How you name it really just depends on how you're using the design. One reason the study design straddles the descriptive and analytic groups is because exposure and disease are assessed simultaneously, so you cannot establish temporality with a cross-sectional design. These designs are used for surveillance programs or estimating prevalence of risk factors, exposures, and outcomes in a population, planning or administering preventive or healthcare services, establishing preliminary evidence for a causal relationship, and to examine the association between exposure and disease onset for chronic diseases where researchers lack information on time of onset. In this study design, exposure and disease status are measured at the same point in time. Any comparison groups are created within the sampled population after data collection and are determined by the association you want to investigate at the time, which of course should be based on previous evidence or hypothesis. Sequential cross-sectional studies are administered over time, but do not follow up with the same people. A new sample of the population is taken each time the survey is administered. These are what we often call prevalence or surveillance studies, and examples are the MIX study in Laos or the National Health and Nutrition Examination Survey, or NHANES, in the United States. With surveillance prevalence cross-sectional studies, you can collect data on many variables that can be evaluated as cofactors, modifiers, confounders, etc. But you do need to adequately power your analysis considering all of these cofactors. In these studies, the measures of frequency of association that are most commonly used are prevalence, prevalence ratios, prevalence odds ratios, and regression modeling to include covariance. A cross-sectional study often takes this form, where you sample a study population, gather data on exposure and disease, or outcome, which are measured at the same time, and then you can divide your groups into 4 possible exposure disease outcome groups: those who are exposed and have the disease, those who are exposed and do not have the disease, those who are not exposed and have the disease or outcome, and those who are not exposed and do not have the disease or outcome. The Lao mix data is an excellent example of a cross-sectional prevalence study that is conducted regularly, but with a new sample each time. With a survey like mix, data are collected on a number of social indicators, so you have many exposures and outcomes that you can use to explore associations. For example, you might believe that women with health insurance coverage may be more likely to be breastfeeding their children at 2 years of age. This is a positive exposure, having health insurance, and a positive outcome, current breastfeeding, but you could also consider being uninsured as the exposure and not breastfeeding as the outcome, as long as it makes sense for your research question. And you cannot determine which came first, being insured or breastfeeding, but you can break it into these 4 possible exposure outcome groups for analysis. In descriptive studies of this design, we estimate the prevalence of a health outcome or risk factor first. Prevalence can be assessed at either one point in time, point prevalence, or over a defined period of time, period prevalence, which may be required when it takes time to accumulate sufficient information on a disease in a population. An example may be estimating what proportion of children seen in a clinic over a year have stunting. Typically, we don't bother specifying whether we're measuring point or period prevalence, but you see period prevalence more often in surveillance, which uses time to define the surveillance period. And in this example, our point prevalence may be that 12 out of 48 children seen on one day have stunting, so the prevalence is 0.25 or 25%. Period prevalence may be that 1,836 children have stunting of 8,000 children seen in the clinic in 1 year, which would give us 23% prevalence of stunting. In analytic cross-sectional studies, data on the prevalence of both exposure and a health outcome are obtained for the purpose of comparing health outcome differences between the exposed and unexposed. I've created a table in which obesity is the outcome of interest and high consumption of sugary drinks or sodas, sugar-sweetened beverages is the exposure. You can calculate the prevalence of the outcome among the exposed, as seen here with PE, or prevalence of exposed, and find the prevalence of obesity among children who have high consumption of sugary drinks. So this is among the exposed. The prevalence among the exposed is about 23%. Then you can find the prevalence of obesity in the unexposed, PU here, or those who have low consumption of sugary drinks. So the prevalence of obesity among children who have low consumption of sugary drinks, or the unexposed groups, is about 4%. Again, the statistical hypothesis for testing proportions, which is what we see here in the table, are that the null hypothesis is proportions are equal, and the alternative hypothesis is that proportions are not equal. In this example, the null hypothesis would be that the proportion of high sugary drink consumers among those with obesity is equal to the proportion of low sugary drink consumers among those without obesity. Among those with obesity. And the alternative hypothesis would be that the proportion of high sugary drink consumers among those with obesity does not equal the proportion of low sugary drink consumers among those with obesity. You can then calculate a prevalence odds ratio, which is AD over BC. And the interpretation of this is the odds of high consumption of sugary drinks in the group with obesity were 7.9 times the odds of high consumption of sugary drinks in the group with no obesity. Or you can say the odds a person with obesity has high consumption of sugary drinks are 7.9 times the odds that a person without obesity has high consumption of sugary drinks. Cross-sectional studies are limited in evaluating risk. You can calculate a prevalence ratio, but this and the prevalence odds ratio are not valid estimates of a risk ratio or rate ratio, so don't use them interchangeably. And remember to use the term odds when you're talking about an odds ratio, not likelihood. In a prevalence ratio, it compares the proportion of exposed persons who are diseased with the proportion of non-exposed persons who are diseased. But typically, the prevalence odds ratio is a better measure when you have longer risk factors or a greater period of time between the exposure and the outcome developing, as in most chronic diseases. And the prevalence ratio is better for more acute onset of outcome or outbreaks. But chances are you'll be doing a more advanced regression or logit, and we'll discuss these approaches more in Module 7. You'll see a lot of debate about what to use for cross-sectional studies in the literature, but you're good with using prevalence and looking at a prevalence odds ratio before you move into your regression analysis. The types of bias we see in surveillance, prevalence, cross-sectional studies are antecedent consequence bias, which is really a fancy way of saying we cannot determine temporality between the exposure and disease status. It's like the classic question, which came first, the chicken or the egg? Survival bias is what we were just talking about in the prevalence ratio, prevalence odds ratio debate. And that is when exposure affects the survival time, and those who survive longer with a disease end up having a higher probability of being counted in the numerator of a prevalence proportion. Your results end up being biased. And a healthy worker effect is that healthy people are often more willing to volunteer and be a part of these types of surveys and cross-sectional designs. These types of studies are able to be done fairly quickly and anonymously if needed, although there still is a tremendous amount of effort and setup that goes into designing and implementing the methods of a cross-sectional study. It's lower cost than any other analytic study and fairly efficient. You can get prevalence of exposures and health outcomes, multiple types, and can both generate and test hypotheses. It does require a very thorough training of study staff, recruitment, data collection, and careful monitoring of adherence to study protocols, as well as a very careful selection of measures, which we'll discuss in a topic 6.6, 7, and 8. This is one of the most generalizable study designs if you select a representative sample, but its rigor is reduced by not having temporality, there are no measures of risk, and study participants aren't randomly allocated to an exposure group. A few examples of these types of studies, particularly in prevalence and surveillance, are the Multiple Indicator Cluster Survey or Laos Social Indicator Survey, the MIC survey, a caregiver survey on children's consumption that was in the World Food Program snack study that I showed an example of earlier, the National Health and Nutrition Examination Survey in the United States that I mentioned. We have many national surveys here in the US. I like the Health Information National Trends Survey, and we have the Behavioral Risk Factor Surveillance System and the Youth Behavioral Risk Factor Surveillance System, which regularly assess behaviors and risk factors among the United States population. Here is an example from the mixed data, the Global Multi-Indicator Cluster Survey. It's the Social Indicator Survey 2 from 2017. And I thought that this was a really nice visualization, which is so important, of data that are collected in the mixed survey on infant and young child feeding. And it shows the stages of breastfeeding and additional feeding over time. And then underneath each of these stages that are represented on a timeline, it provides the proportion of respondents who met the a particular value for that standard, such as minimum meal frequency, minimum diet diversity. If you would like to look at the methods and the report for the mixed data, I've included the link here. I'm sure many of you are already very familiar with the survey or involved. But one thing that I find very helpful when designing a cross-sectional study is to read over the methods of administration and how data are collected in other well-established cross-sectional surveillance or prevalence studies. That helps me understand what is a gold standard or a best practices way of approaching data collection in a cross-sectional study. This is sample data from the Caregiver Survey on Children's Consumption, which was a small study, is a mixed methods, but included this cross-sectional survey with primary caregivers of children ages 6 to 11. There were only 60 caregivers each in Laos, PDR, and the Philippines, but it gives us some information about food and beverage consumption. In the figure on top, we look at the time of day certain foods and beverages were usually consumed in the past week. And on the bottom graph, we see the frequency of usually consuming unhealthy foods or beverages at school in Laos PDR among those who consumed in the previous week. This just gives us some foundational descriptive patterns of who is eating what type of snack or unhealthy foods and where. If you would like to visit this, I believe that we have a copy of this study, but I do not have a link here in the slide. The National Health and Nutrition Examination Survey, as I mentioned, is a part of the National Center for Health Statistics, the Centers for Disease Control and Prevention in the United States. It's a nationally representative sample of about 5,000 participants per year, and 15 of the counties that they sample from are visited each year. The interview includes a survey of demographic, socioeconomic, dietary, and health-related questions, and there is an exam component that consists of a medical, dental, and exam physiological measurements, as well as laboratory tests conducted by well-trained individuals. Again, you can click this link here if you'd like to look at the methods of how NHANES is administered, and I included a sample of data from a report on dietary supplement use among adults in the United States from 2017 to 2018, and it shows what vitamin supplements are used among adults of different age groups. Finally, additional study planning for surveillance, prevalence, and cross-sectional studies. These are the same types of questions that you will ask yourself about methods and analytic plan for any study that you're going to conduct. I'm including this slide here, but we'll have to ask these questions of ourselves throughout all of the modules and throughout all of the development and implementation of your studies. In sampling and recruitment, how will you sample your population? How do you recruit people and compensate them for participation? Who will do the recruiting? Will that person be representative of the population from which your sample comes? What is your sample size? How are you going to reduce bias and make your sample representative of the population? How will you train your study staff and create protocols and ensure they adhere to those protocols? What measures are you going to use for exposure, outcome, and any other covariates? How are you going to collect the data? Interview, an online survey, CADI or CAPI, which is computer-assisted, telephone or personal interviews? How will you store your data and validate your data? And how do you plan to assess relationships and covariates? How are you going to conduct your univariate, bivariate, and multivariate analysis? And how will you reduce bias? But don't worry, these are questions that we will be addressing throughout Module 6 and Module 7 of this series. Finally, descriptive studies are the foundation upon which we build research evidence. Choosing your study design and how you plan for that design takes careful consideration and planning, but doing so will result in rich data that will become the foundation for future inquiry and public health action. Thank you.